Welcome to episode 9 of the disconnect between atria and ventricles, AV blocks, a crucial area in rhythm analysis where communication between the atria and ventricles is disrupted. Welcome to Master the Beat, from basic EKG to life-saving ACLS series. Before we move on, it's crucial to understand the monumental impact of the Human Genome Project. Its research dated from 1990 to 2003. It's a groundbreaking international research effort that mapped 3 billion base pairs of human DNA and identified around 25,000 human genes. The Human Genome Project revolutionized healthcare by revealing the genetic basis of diseases. The findings of the Human Genome Project are critical for healthcare professionals as they debunk many race-based myths, particularly in relation to health and disease susceptibility. For instance, it was once believed that certain races were genetically predisposed to specific diseases, like sickle cell anemia was taught to us to be categorized as a Black person's disease. In reality, sickle cell is not linked to race, but instead linked to a genetic trait that evolved in populations exposed to malaria. This adaptation developed as a response to the malaria endemic in regions such as Africa, the Mediterranean, and South Asia. The Human Genome Project clarified that while some genetic conditions are more common in certain populations, the disease prevalence is tied to genetic mutations linked to geography. They are not exclusive to any race. The Human Genome Project dispelled the notion of racial genetics and highlighted the need to understand genetic diversity across all populations. Now back to AV blocks. AV block. An AV block refers to an arrhythmia in which there is a delay or failure in the conduction of electrical impulses from the atria to the ventricles. This interruption can occur at various points within the conduction system, such as in the AV node, bundle of His, or in the bundle branches. AV blocks are classified according to the type and location of the block. A first-degree AV block, impulses are delayed in the AV node, but all are conducted into the ventricles. Second-degree AV block, Mobitz I and Mobitz II. Some impulses are conducted to the ventricles and some are blocked. In third-degree AV block, all impulses are blocked and none are conducted to the ventricles. Location of the block. If the block occurs at the AV node or bundle of His, the QRS complex will have a normal duration of less than 0.10 seconds. If the block is located in the bundle branches, the QRS complexes are typically widened as the delay affects conduction through the ventricles. Now let's review the traditional steps in diagnosing AV blocks. Step number 1. Look for P waves. Is there one P wave to each QRS or more than one? Step 2. Measure the regularity of the atrial rhythm, the P to P interval, and the ventricular rhythm, which is the R to R interval. Step 3. Measure the PR interval. Is the PR interval consistent or does it vary? The PR interval is the key to identifying the degree of this AV block. Measure the QRS complex as your fourth step. Is it narrow or wide? The width of the QRS complex and the ventricular rate are keys to identifying the location of the block. The lower the block is located in the conduction system, the wider the QRS complex and the slower the rate. Let's review ECG characteristics in the types of AV block. First degree AV block is characterized by a prolonged PR interval. It's going to be greater than 0.20 seconds, with each atrial impulse eventually conducted to the ventricles. But remember, the PR interval is constant. The rhythm is generally regular and the QRS duration remains normal. A second degree AV block, type 1 Wenckebach. The PR interval progressively lengthens until a beat is dropped. Typically occurs at the AV node level and often has a normal QRS width. Second degree AV block, Type 2. The PR interval is constant, but some P waves are not followed by QRS complex, indicating a more unpredictable block. QRS may be wide if the block is in the bundle branches. Third degree or complete AV block. There is no conduction of atrial impulses to the ventricles, resulting in atrial and ventricular rhythms that are independent of each other. A ventricular escape rhythm often takes over, and the QRS width depends on the origin of this rhythm, but most likely wide. Now let's do an overview on a first degree AV block. First degree AV block is considered the mildest type of AV block. In this condition, the electrical impulse originates in the sinus node and proceeds to the AV node as expected, but it experiences a delay within the AV node before being conducted to the ventricles. This delay results in a prolonged PR interval greater than 0.20 seconds. But remember, despite the delay, each impulse is still conducted through the ventricles, and therefore every P wave is followed by a QRS complex. Since the conduction delay is localized within the AV node itself, the QRS complex remains within normal duration, typically under 0.10 seconds. In clinical practice, this block often accompanies an underlying rhythm, such as normal sinus rhythm with a first degree AV block, and it's essential to interpret both the underlying rhythm and the AV block in ECG analysis. So let's again review a first degree AV block ECG characteristics. The key is the prolongation of the PR interval. In a first degree AV block, the defining feature is that PR interval that's longer than normal, which is greater than 0.20 seconds. This indicates a delay in conduction between the atria and ventricles, specifically within the AV node. Remember, while it's delayed, every impulse still makes it through to the ventricles. The atrial and ventricular rhythms remain regular because despite the delay, each P wave is still conducted to the QRS, and your PR interval is constant. Thus, every P wave you see will be followed by a QRS complex, maintaining a consistent rhythm. Normal QRS complex, since the delay happens within the AV node, above the level of the ventricles, the QRS complex duration stays normal, limits typically under 0.10 seconds. This helps us differentiate first-degree blocks from more severe AV blocks that involve the bundle of His. A first-degree AV block is often seen in conjunction with an underlying rhythm, like normal sinus rhythm or sinus bradycardia. So when interpreting an EKG, be sure to identify both the rhythm and the block. Now let's analyze this practice strip. Let's start with the rhythm. The rhythm is regular, as we can see from the consistent R to R intervals across the strip. Each QRS complex is evenly spaced. Rate. The heart rate here is 48 beats per minute, or approximately 40, because I see 4 QRS complexes in a 6-second strip. This bradycardic rate suggests a slower than average impulse initiation. We have sinus P waves present, which means that each P wave originates from the sinus node. Additionally, there is 1 P wave for each QRS complex, showing consistent conduction from the atria to the ventricles. This relationship is crucial for confirming that the atrial and ventricular activities are in sync. PR interval. Our PR interval is consistent but greater than 0.20 seconds, averaging about 0.28 seconds, and remains consistent throughout the strip. This is a prolonged PR interval indicating a first-degree AV block. While it shows delayed conduction from atria to the ventricles, it does not drop any beats. Each P wave is followed by a QRS complex. The QRS complex is normal in width, measuring 0.08 seconds. This tells us that the delay is occurring above the level of the ventricles, specifically at the AV node or just before the bundle of His, since the QRS is not widened. Additional findings, you see a U wave followed by a T wave on the strip. U waves can sometimes appear in normal individuals, but they can also be associated with certain conditions such as hypokalemia or bradycardia. While not definitive in itself, it's an observation worth noting in clinical context. In summary, putting this all together, we're looking at a regular rhythm with a sinus bradycardic rate, sinus P waves preceding each QRS, a prolonged PR interval indicating a first-degree AV block, and a normal QRS complex. The U wave is an additional observation, but doesn't change the primary interpretation of sinus bradycardia with a first-degree AV block. As a reminder, a first-degree AV block is often asymptomatic because it typically doesn't disrupt the heart's overall function. Generally, no treatment is necessary unless it's causing symptoms, as this block simply reflects a prolonged PR interval without drop beats. When intervention is needed, the patient presents with some symptoms from bradycardia related to the block, such as hypotension, dizziness, or syncope. Especially if the ventricular rate has slowed, we should initiate treatment following the ACLS bradycardia protocol, starting with atropine, and also, if needed, you can add transcutaneous pacing and or dopamine and or epinephrine drip. Any drugs causing the AV block should be discontinued. Now on to our next AV block. That might be just the most famous one of all. Second-degree AV block, Mobitz I, type 1, or as many of us know it, Wenckebach. Its catchy name and unique rhythmic pattern make it one of the most recognizable blocks in ECG analysis. This block shows up with a characteristic beat pattern, and unlike some of the other blocks, it usually isn't a cause of major concern. Let's go over ECG characteristics of Wenckebach, starting with the key component of rhythm. The overall rhythm is irregular, but there is a pattern to the irregularity. As the PR interval progressively gets longer, the rhythm becomes irregular, and after a drop beat, the cycle resets. Next is rate. The atrial rate, P waves, is typically normal, but the ventricular rate, QRS complexes, may be slower due to the drop beats. Since not every atrial impulse makes it through the AV node to cause a ventricular contraction, the ventricular rate will be lower than the atrial rate. Next is our P wave. The P waves are normal in shape and size, and they occur regularly. However, not every P wave is followed by a QRS complex due to the AV node blocking some impulses. Remember, all our P waves are uniform across the strip. The PR interval. The PR interval is the defining characteristics of Wenckebach. You will see progressive lengthening of the PR interval with each consecutive beat. Eventually, a P wave occurs without a QRS following. This is the drop beat. And then the cycle resets with a shorter PR interval, QRS complex. The QRS complexes are typically normal in width, narrow, since conduction through the ventricle is not affected when the signal does pass through the AV node. However, after the drop beat, when the AV node fails to conduct the impulse, there will be a missing QRS complex. To summarize, Wenckebach rhythm has an irregular pattern due to the progressive PR interval prolongation, eventually leading to a dropped QRS complex. After the block beat, the cycle restarts. The key feature to remember is that the PR interval gets progressively longer until a beat is missed. Now let's do a practice strip. Let's go through the analysis of this EKG rhythm, starting with the rhythm. The rhythm here shows a regular atrial rhythm, meaning the P waves are consistently spaced, indicating that the sinus node is pacing the atria at a regular rate. However, the ventricular rhythm appears irregular, which is often due to an intermittent conduction block between the atria and ventricles. Next, let's look at the heart rate. For this rhythm, the atrial rate is 75 beats per minute, when the ventricular rate is slower at around 50 beats per minute. This difference suggests that some atrial impulses are not being conducted to the ventricles, reducing the overall ventricular rate. Our next assessment is the P waves. The P waves here are sinus in origin, regular, and consistently present. Not every P wave is associated with a following QRS complex due to the block. The PR interval is a critical measurement here. We can see that it lengthens progressively, ranging from 0.28 to 0.40 seconds. This gradual lengthening is followed by a dropped QRS complex, which is typical of a second-degree heart block, specifically Mobitz I, Wenckebach, where the PR interval increases until a beat is skipped. Our next assessment, the QRS complex. QRS complex width is within a normal range, measuring between 0.08 and 0.10 seconds. This indicates that the ventricles are depolarizing normally when they do receive the atrial impulses. In summary, this EKG shows a regular atrial rhythm with an irregular ventricular response, a progressively lengthening PR interval, and a dropped QRS complex, consistent with Mobitz I, Wenckebach. This type of block is often benign but may require monitoring, especially if symptoms are present. Mobitz I or Wenckebach is most likely asymptomatic and does not require treatment. If the ventricular rate is bradycardic and the patient is symptomatic, ACLS bradycardia protocols should be followed. Atropine first, and then transcutaneous pacing and or dopamine drip and or epinephrine drip. Drugs causing AV blocks should be discontinued. The next block is second-degree AV block, Mobitz II type 2. Understanding Mobitz II second-degree heart block extends beyond EKG interpretation to include clinical implications, associated symptoms, and management strategies. Here are the key aspects: pathophysiology and clinical significance. Mobitz II occurs due to a conduction block below the AV node, typically in the bundle branches, making it a more serious condition than Mobitz I, Wenckebach. It can progress to complete heart block, third-degree AV block, especially in patients with structural heart disease. This type of block indicates a higher risk for sudden cardiac arrest, necessitating prompt and appropriate response. Signs and symptoms can include fatigue, dizziness, presyncope, or syncopal episodes due to reduced ventricular response and low cardiac output. Providers should be aware of possible hypotension, lightheadedness, chest pain, or signs of heart failure in Mobitz II, as it can lead to hemodynamic instability. Mobitz II is less common than Mobitz I, but more serious. Mobitz II has the potential to progress suddenly to third-degree AV block or ventricular standstill with little or no warning. Mobitz II commonly occurs with an anterior wall MI. Other causes include acute myocarditis and degeneration of the electrical conduction system as seen in the elderly. Syncopal episodes called strokes atom attack are associated with Mobitz II. Now let's analyze the EKG characteristics that define a second-degree AV block Mobitz II type 2. In Mobitz II, we typically see a regular atrial rhythm because the sinus node is firing consistently. However, the ventricular rhythm is often irregular due to intermittent drop beats, where certain atrial impulses are not conducted to the ventricles. Next is the heart rate. The atrial rate will generally reflect a regular sinus rhythm, often within normal limits. The ventricular rate, however, is slower, and its rate will vary depending on the number of drop beats. This difference in rate is due to the block conduction from the atria to the ventricles. Next, the P wave. We observe normal sinus P waves that appear consistently and regularly. Importantly, not every P wave is followed by a QRS complex, which is the hallmark of this block type. The presence of more P waves than QRS complexes indicates a conduction block within the AV node or lower. And one of the most defining characteristics is the PR interval. Once you define this as AV block, this is the only AV block that has a consistent PR interval. In Mobitz II, the PR interval remains constant on conducted beats, unlike Mobitz I, Wenckebach, where the PR interval lengthens progressively. In Mobitz II, the PR interval stays the same for each QRS complex that follows the P wave. This predictable PR interval followed by a sudden drop in QRS complexes is the key indicator. The QRS complex. The QRS complex can vary in width depending on where the block occurs. If the block is higher up in the AV node, the QRS may be narrow. However, in most cases, Mobitz II is associated with a block lower in the conduction system, often resulting in wide QRS complex, which can indicate an involvement of the bundle branches and a more serious prognosis. Remember, Mobitz II is characterized by a regular atrial rhythm, intermittent drop QRS complexes, a consistent PR interval on conducted beats, and often a wider QRS complex. This type of block is significant because it can progress to a complete heart block and may cause symptoms of bradycardia or low cardiac output. Recognition and prompt intervention are essential for managing Mobitz II effectively. Immediate management in ACLS. In ACLS, the primary approach is to stabilize the patient. If symptomatic, Mobitz II requires close monitoring and potential intervention. Bradycardia in Mobitz II may not respond effectively to atropine, which is typically used for symptomatic bradycardia first line as the block occurs in the distal conduction system. Transcutaneous pacing is often recommended as the first line of action for symptomatic Mobitz II. Providers should be ready to escalate to transvenous pacing if transcutaneous pacing is insufficient or unavailable. Dopamine or epinephrine infusions may be used as a bridge to improve heart rate and cardiac output if pacing isn't immediately possible. Long-term management. Mobitz II often requires a permanent pacemaker. ACLS providers should be prepared for transfer to a higher level of care where electrophysiology consultation and potential pacemaker placement can be arranged, particularly in patients who experience symptomatic episodes. Now let's move on to the third degree or complete heart block, or AV block. In a third degree block, none of the atrial impulses are conducted into the ventricles. The result is an independent atrial and ventricular rhythm. A ventricular escape rhythm usually assumes the role of the pacemaker with QRS width determined by the site of the origin of the ventricular escape. Most likely, third degree AV block will have a wide QRS. Now let's review some associations with third degree AV block. One is the risk of ventricular standstill. The ominous thing is that it may suddenly advance to ventricular standstill with no warning at all. Third degree AV block may occur, although less commonly, in the setting of inferior wall myocardial infarction and anterior wall MI. For unstable patients with third degree AV block occurring along with an anterior wall MI will probably require permanent pacing, such as the implantation of a pacemaker. Other causes include Lyme disease, digitoxicity, age-related or other forms of degeneration of the heart's electrical conduction system, Stokes-Adams attack, inexplicable sudden episodes of fainting associated with complete heart block result from temporary lack of blood flow to the brain because of the block. The ECG characteristics of a third degree heart block include, starting with the rhythm, atrial and ventricular rhythms are regular but independent of each other. Next is the heart rate. The atrial rate is usually normal, 60 to 100 beats per minute, but the ventricular rate is usually slower, typically around 20 to 40 beats per minute, depending on the escape pacemaker. Next is the P wave. P waves present, but there is no consistent relationship with the QRS complexes. Atria and ventricles beat independently. PR interval varies greatly, no pattern due to dissociation between the P waves and the QRS complexes. QRS complex, now that may be narrow, less than 0.12 seconds if the block is above the bundle of His, or wide if it's greater than 0.12 seconds if the escape focus is in the ventricles. Now let's try this practice strip. Starting with the rhythm, if I march out my ventricles, they will be regular, and if I march out my P waves, they would also be regular. Heart rate. Atrially, I have a heart rate between 70 to 80 beats per minute, and my ventricular rate is about 30 beats per minute. My P wave. I have P waves. Those are sinus. Some are found hidden in T waves and QRSs, but there is the PR interval that varies greatly. There's no association between my P waves and QRSs, and my QRS width is 0.12, which means the escape focus is in the ventricles. This shows that I have a third degree AV block. Treatment of third degree AV block according to ACLS guidelines. Third degree AV block, also known as complete heart block, is a serious cardiac condition where there is no electrical conduction between the atria and ventricles, leading to severe bradycardia and decreased cardiac output. According to Advanced Cardiac Life Support (ACLS) guidelines, the treatment for third-degree AV block involves following the steps. Always assess and stabilize the patient and ensure to complete your ABCs. Place the patient on a cardiac monitor to observe heart rhythms continuously. Also, obtain a 12-lead electrocardiogram to confirm the diagnosis of third-degree AV block and to identify the level of the block. Narrow versus wide QRS complexes. Initiate temporary pacing. Start with transcutaneous pacing (TCP). TCP is recommended for patients with symptomatic bradycardia due to complete heart block. If the patient is conscious and TCP is uncomfortable, consider administering analgesics and sedative. Initial pharmacological intervention for ACLS bradycardia protocol is to use atropine, but atropine may be ineffective, especially in complete heart block with a wide QRS complex, infranodal block. Always consider your dopamine and epinephrine drip. Prepare for transvenous pacing or permanent pacemaker. Consult your cardiologist, who is going to be the expert evaluator. A cardiologist can assess for underlying causes and additional treatment for further management. So hopefully this will help some people. It's called the couples connection analogy for AV block. Think of the AV node and ventricles as a couple trying to communicate, where the AV node represents one partner initiating messages or impulses, and the ventricles are the other partner receiving and responding to the messages. First degree AV block, the patient or partner in this relationship, the AV node, one partner, always gets its message across to the ventricles, the other partner, but there's a delay. Imagine one partner is always a bit late to respond, but still does so consistently. The relationship still works, just a bit slower than usual. Second degree AV block type 1, Mobitz I, or Wenckebach. The fading relationship. Here, the AV node partner starts getting tired, so each message is delayed a little bit more each time. Think of it like one partner gradually responding less and less until eventually don't respond at all to one of the messages. After that missed response, the cycle repeats. It's a sign that one partner is losing patience or energy, but still tries to keep up. Now, second degree AV block type 2 Mobitz II, the unpredictable partner. In this case, the AV node, or one of the partners, sometimes doesn't get its message through without any pattern or warning. Picture it as one partner randomly ignoring the other's attempts to connect. There's no gradual decrease in connection, just unpredictable drop in communication that could happen anytime. Now, to the third degree AV block, complete heart block, the silent treatment. Here, the AV node and the ventricles have just stopped talking to each other entirely. Each partner is living their own life independently, creating separate rhythms. No messages get through, so they act completely independent. This represents a complete breakdown in communication, where each partner is unaware of the other's intention and living their own life. Hence, they're not together anymore. Become a member today, and I'll share my quick and effective method for identifying AV blocks and interpreting ECGs. I'll teach you how to pinpoint the specific block, simply analyzing the PR interval within just 3 seconds. This method simplifies the process, helping you master ECG interpretation with confidence. That concludes Episode 9 on AV block. On our next episode 10, Beyond the Bundle, Decoding Ventricular Rhythms, we learn ventricular rhythms and bundle branch blocks. So don't miss this one. In episode 9, we'll review PVCs, ventricular tachycardia, ventricular fibrillation, idioventricular rhythms, and bundle branch blocks. Don't forget to become a member. Of course, it also opens extra resources when you become a Novamind member, like practice strip and exclusive rhythm interpretation tricks. Don't forget to subscribe and like so you don't miss another Master the Beat episode. See you in episode 10.